Thank you.
Thank you for the moderator. Actually, I'm not professor yet. Yeah. Maybe Dr. Pandey misleading this. Uh, uh, Good afternoon, ladies and gentlemen. Sorry, I start for the second topic of this symposium. Thank you for the AUTA committee that invite me to giving this topic on this symposium. I'm Butuan Natusta from Surgical Oncology Division, Prof. Ngurah Hospital, Udayana University. I will talk about surgery approach of mixed nodule in diffuse goiter. This is the outline of the presentation. I will more focus on the third, on this, sorry. Ya, ada. Oh, iya, ini ya. Okay, I will more focus on the surgical approach of mixed nodule in diffuse goiter. And thank you for speaker, Prof. Diah, that's explained about the goiter clearly. We start from the indication, principle of surgery, the surgical procedure, and the complication of the surgery. Mixed nodule, easily we call it Plummer disease. Yeah, that's a rare cause of hypothyroidism and thyrotoxicosis than grave disease. So in easy way, I will say that surgery in the grave disease is more difficult than Plummer because of the potential complication. This, yeah, the toxic multinodular goiter, high incident in relative morely incident in the iodine deficient area or poor rural area, and start from one toxic nodule and then increase thyroid hormone and then suppress growth from the adjacent normal thyroid parenchyma. In general, Plummer disease is differentiated from grave disease in that extrathyroidal manifestation and thyroid antibodies are not present. That's the difference between the grave and the Plummer. And the etiology of Plummer can be divided primary and secondary factors. The primary mainly genetic predisposition to functional heterogeneity of normal follicular cell, causing higher probability of the autonomous toxic nodule to arise. And the secondary factors include elevated thyroid stimulating hormone, such as and also smoking, stress, and others. Yeah. And the pathogenesis of the Plummer disease is started from the presence of a chronic low-grade and intermittent stimuli, such as high TSA level, genetic mutation of the thyroid, and the stimuli then trigger the hyperplasia of the thyroid gland and form one nodule or multinodule, and due to their growth abnormality, became autonomous and independent of the TSH feedback. Yeah. An example, the lack of iodine causing the low production of thyroid hormone, then trigger the chronically high TSH levels. This stimuli will causing a growth autonomous nodule and is the beginning of the as the Plummer disease. So for clinical manifestation of the Plummer is initially patient came with euthyroid presentation. The cause of the disease is long and slower to manifest, the thyrotoxicosis, such as weight loss and so on. The Plummer disease often missed because, increase of T3, instead most of commonly examine the free T4. So the coexisting cancer is more common in men, and non-functional nodule. So the possible sign and symptoms that arise are the compressive symptom or obstructive symptom, like dysphagia and dyspnea. And the second, mediastinal or intrathoracic goiter sign, like hoarseness, dyspnea, stridor, and cough. And the specific symptom is arise from the manipulation from iodine imaging or treatment. And the most, there are subclinical thyrotoxicosis symptom. And the diagnosis, similar with any other thyroid condition, the workup diagnostic of the Plummer disease include thyroid ultrasound that then be classified as a thyroids, classified as thyroids, thyroid imaging report and data system, and continue the examine, then followed by fine needle aspiration for suspicious cases, then classified into Bethesda classification. In Plummer disease, some workup will have a distinct finding. In the laboratory study, we will found that increased T3 level, but a normal T4 and free T4 or T4 or free T4 normal, but and T3 thyrotoxicosis. Of the resource, if the resources are available, thyroid scan could be performed. We will find areas of increased uptake and suppress area interspread. Second, we will administer suppressive dose of thyroid hormone does not affect the function of the nodule, but decrease the uptake of the extranodular tissue. And the three, we will find administer exogenous thyroid stimulating hormone could increase or restore the radionuclide uptake in the question tissue. So, from the evidence-based management of toxic multinodular goiter by Petrofield and et al., we shown that the current treatment for Plummer disease can be divided into medication, iodine therapy, and surgery. Anti-thyroid medication have not been widely accepted, recommended only as adjunctive to control hypothyroidism and preparation for more definitive treatment. Prior to surgery, patients should be rendered euthyroid with thionamides, and tachycardia with beta blocker. But Lugol solution should be avoided in the pre-treatment of Plummer disease. So the treatment of choice for medication is radioactive iodine therapy. Historically, as initial, maybe we'll explain by next speaker. And percutaneous ultrasound guided ethanol injection. To be honest, I really no experience with this method. There are some disadvantages such as multiple session, and patient may experience severe pain, complication of the recurrent laryngeal nerve, and abscess formation. Iodine treatment, there's also iodine therapy, but I will not talk further in this slide because we'll explain by next speaker. And surgical treatment, this is the main topic of my talk. And the surgical treatment is, we can call that definitive, definitive. Particularly for this patient having, especially in patient with obstructive symptom or compressive symptom. And second is concern for malignancy. So the advantage of surgery include hyperthyroid state will cure immediately. And the second, low recurrence rate, free from the large goiter condition or volume, and it's associated with cardiac manifestation. Simultaneously, treat the thyroid cancer dealing with the toxic multinodular goiter that is said that happen in 3 to 5% cases, the coexisting cancer. But maybe this is a iceberg phenomenon, because of in the other study, the cohort study said that the incident increased into 18%. But surgery also have disadvantages because the possible complication such as hypoparathyroidism because of injured parathyroid, and injury to the superior and laryngeal recurrent nerve, and others kind of surgery complication like bleeding, infection, and so on. The approach used to determine the needs for surgery are based on guideline from European Thyroid Association. Patients with thyroid nodule present firstly perform ultrasound, TSH examination, and in some area calcitonin examination. Low and high TSH continue by thyroid hormone and thyroid antibody examination. Normal TSH continued by fine needle aspiration examination. And based on the previous examination, ultrasound and FNA finding then classified as by thyroids system for ultrasound and Bethesda for FNA. This is thyroids. This is the Bethesda, And in the end, guideline indicates surgery for such as case. First, symptomatic nodular thyroid disease. Second, nodule that have been classified as benign at cytology and or US and become symptomatic over time. The third, calcitonin level higher than the established cutoff. The fourth, responsive calcitonin after stimulation test in red mutation gene carriers. 5, nodules with indeterminate cytology, Bethesda class 3 or 4, that are not suitable for active surveillance, maybe due to the large size, high suspicious of malignancy and symptomatology. And 6, the nodule with the Bethesda class 5 or 6. And the basic principle of thyroid surgery are voice control. Second, parathyroid preservation. And the last is precision surgery. The voice control attained by carefully preserve the nerve that positioning around the thyroid gland. And the second is we need to preserve the parathyroid carefully. And the third, the surgery should be done precisely and meticulous to prevent damaging other structure adjacent to thyroid tissue. There are 6 or more, maybe, type of thyroidectomy surgery, but in our center, we mainly perform small lobectomy and total thyroidectomy. The reason being the experience in our center shown that performing subtotal thyroidectomy still leave a problem with us. The patient still have to take exogenous thyroxine because not adequate thyroxine production. And the second, the possible recidivate mass and also higher risk of recurrency. And also the third reason is when the thyroid is recurrent, the surgery is difficult by the next or following surgeon after years. The step of the surgery as follow. This is the same as the normal or conventional thyroid surgery by positioning incision and thyroid exposure, releasing superior pole, identifying parathyroid, releasing inferior pole, identification of recurrent laryngeal nerve, and removing thyroid gland. In positioning, patient will be put in supine position and a bit semi-flower position with neck extended and surgical roll to the back. Need collaboration with anesthesiologist carefully. After positioning, the patient then mark before aseptic and wrapping procedure. And the most common incision used, we call it coher collar incision. But there is some modification if an alternative when we need more exposure, such as a midline incision, midline. So yeah, after the coher, we need another exposure. We do a midline incision, and extended coher, the second extended coher, and also the maybe if we need more exposure, longitudinal incision along the anterior border of sternocleidomastoid. Yeah, this one. And the third step is after the incision, skin flap made superior and inferiorly. The muscle then divided apart to expose the thyroid. When the thyroid exposed, we proceed to releasing the superior pole of the thyroid.
I'm sorry, Prof. Doc. You have 3 minutes left.
Oh, thank you. Dissect the overlying strap muscle of the thyroid gland without injuring the subcapsular vessel. Cricothyroid space should be identified and dissected. And the main structure need to be preserved is superior laryngeal nerve. Yeah, superior laryngeal nerve. It need to be preserved for avoid phatic voice. Next step is after superior pole release, we should be careful to preserve the parathyroid gland. This is the important, also the important things during the surgery. Surgeon and the assistant should be vigilant in identifying the parathyroid glands. Superior parathyroid gland can be often found separate to tubercle sucracandle. Yeah, tubercle sucracandle is part of the thyroid that produces parafollicular cell C, and inferior parathyroid gland is usually located 1 centimeter radius from inferior pole of thyroid gland. The gland should be carefully dissected from the thyroid and left in the thyroid gland. So for parathyroid, not only the parathyroid preserved, but also the vascularization into the parathyroid. The next step is the inferior parathyroid gland should be also preserved whilst releasing lower pole of the thyroid. Next, after superior pole release, we should be careful to preserve the inferior parathyroid gland. So, one important structure that should be left intact are recurrent laryngeal nerve. Yeah. The tubercle of supracandle found in 80% of thyroid and most often found lateral to the recurrent laryngeal nerve, with some variation may occur. The surgeon still have to be cautious due to the possible variation of the recurrent laryngeal nerve might be the exposed when the subcapsular thyroidectomy performed. Usually, if we do the subcapsular thyroidectomy, we not find the nerve because already preserved. But sometimes in some variation, the nerve can be exposed, and then we remove the thyroid gland entirely. And this is obtaining hemostasis in the thyroid bed is imperative. Yeah, we put a drain, and the neck closed. Drain is used to monitor, to monitor bleeding. This is the complication of the thyroid from hypocalcemia, injury to the laryngeal nerve, injury to the superior in laryngeal nerve, neck hematoma, infection, and thyrotoxicosis storm. This is the dangerous one of the complication, but less likely in the Plummer compared to the grave. Yeah. So this is the take-home message that pre-operatively we need interdisciplinary collaboration needed in surgery preparation and laboratory and imaging workup diagnosis to assess Plummer disease. Intraoperatively, tissue and gland handling is important to prevent precipitation, thyroid storm, or Plummer disease, and surgeons should beware of higher risk of bleeding in Plummer disease. Postoperatively, we need to be aware of neck hematome, close monitor drain production, and beware of risk of postoperative precipitation thyroid storm in Plummer disease because the thyroid precipitation thyroid storm can be lately. Thank you for the attention.